This conference will now be recorded.
So today we'll be discussing the medical and the surgical management of thyroid disorders. So what are the thyroid disorders? We have a non-malignant and malignant disorders. The non-malignant are hyper and hypo. So in hyper we have thyrotoxicosis, thyroiditis, or subclinical hyperthyroidism. Whereas in hypo we have subclinical hypothyroidism, and we also have a euthyroid state, and then the malignant disorder. So we will discuss one by one. Firstly, we'll discuss the hyperthyroidism. So what happens in hyperthyroidism is um, the thyroid TSH is very less because the T3, T4 are very more in the body. So the TSH becomes less. So what are the conditions of primary, like Graves, toxic macular goiter, toxic adenoma, or all stroma ovaris, or all these are conditions of primary. That is the pathologies at the thyroid level. But when the pathology is at the pituitary or at the hypothalamus, then you will have a then that is known as secretory hyperparathyroidism. Okay, so secondary hyperparathyroidism and thyrotoxicosis without hyperthyroidism means there won't be any thyroid. The thyroid will be in the normal stage, but the patient will have some thyrotoxicosis. So that is known as subacute thyroiditis or silent thyroiditis. So and the thyroid, what is thyrotoxicosis? Thyrotoxicosis. The goal is to minimize the symptoms and reduce hormone production. Okay, and the modalities are antithyroid drugs, radioactive treatment, or surgery. So what do we give? Thyroid inhibitors. So what are the thyroid inhibitors? We give anti-thyroid drugs, that is thianomides, also known as, and the most commonly used drugs are carbimazole, methimazole, and propyl thiouracil. So propyl thiouracil is the drug of choice for the patients in pregnancy who have thyroid, hyperthyroid condition. So the patients have hyperthyroid in the pregnancy state. The drug given is propyl thiouracil, and the most common drug used in hyperthyroid in normal people is carbimazole and methimazole. Okay. We also used to give ionic inhibitors, that is like thiocyanates, perchlorates, or nitrates, but these are seldom used now. They have been abandoned now. Some drugs like to hormone release inhibitors are also used, like iodine, iodide of sodium and potassium, organic iodide. These are sometimes used before surgeries also to bring the stage into the euthyroid state. And in some cases, we also destroy the thyroid tissue by giving radioactive iodine. uh, Sorry for the disturbance. Then radioactive iodine. By giving radioactive iodine, we destroy the thyroid tissue. So iodine 127 is a stable isotope, but generally used are iodine 131, 123, and 125. Most commonly used one is iodine 131 type of isotope is used for radioactive iodine. Destroy the thyroid tissue. So iodine 131, it emits both X-rays and beta rays. X-rays are used in tracer studies, and beta rays are have the destructive effect. Okay. So what are the side effects of the radioactive iodine? When you give the patient a radioactive iodine, the early effects will be the patient will have neck discomfort, They will also have some taste abnormalities, recurrent silentinitis, means the salivary glands, parotid duct, and the submandibular will have inflammation. The patients may also have some nausea and low sperm count. So these are the radioactive iodine. Why the patient will have low sperm count? Because the pituitary axis, means the pituitary can also get sensitized with this radioactive iodine, and as the hormones are required for the sperm count will also might get also decreased. So the patient may also have low sperm count, and the late effects will be leukemia and second cancers and radiation fibrosis. Generally, after the any radiation is given, the patient will have fibrosis. So these are the late effects. Then what is thyrotoxic crisis? It is generally rare, but it's a very life-threatening exacerbation of hyperthyroidism. Thyroid level, the T3 and T4 are more in the body, and it will have a very life-threatening problems to the patient on the table, or it can be pre-op also. So the clinical features will be the patient will have fever, and the patient will have delirium, seizures, coma. The patient might go into coma, vomiting, diarrhea, and jaundice, because that thyroid is spilled into the blood, and it increases the basal metabolic rate of the body, and the patient will have tachycardia. Means the patient can have cardiac failures, arrhythmias. So it's very life challenging problem for the patient when if the patient enters into thyrotoxic crisis. It is precipitated by acute illness or also by sometimes post surgery, and also due to radioiodine treatment of patient. And how do we manage? We have to intensively monitor the patient and give the supportive care, and we have to identify and treat the precipitating cause. Okay, and the drug of choice, antithyroid drug of choice, is propylthiouracil. And 1 hour after the first dose of propylthiouracil, a stable iodide is given to block thyroid hormone synthesis via the Wolff-Chaikoff effect. Means you give the thyroid to the body so that it will not produce more of the TSH, and the thyroid, the T3 T4 levels are maintained. So when the patient enters into the thyrotoxic crisis, the antithyroid drug of choice is propylthiouracil, and then after 1 hour after administering that, we have to give some iodide to block the hormone synthesis. And we also give some propranolol that will reduce the tachycardia and other adrenergic manifestation. And high dose of propranolol will also decrease the T4 to T3 conversion. Some additional treatments like glucocorticoids are given, dexamethasone, as the inflammation is more. So to reduce that inflammation, we give some dexamethasone. Antibiotics if infection is present. We also cool the body, because due to the increase of the basal metabolic rate, the body gets into hyperthermic state. So we cool the body, and we also give some oxygen supplement, and intravenous fluids are given constantly. So that was of the hyperthyroidism. So when you have the patient with hyperthyroidism, you give some drugs like carbimazole, methimazole, or propylthiouracil. You also destroy the tissue by radioactive iodine, and you also give some iodide. Okay. Now what happens? So what to do when the patient has hypo? Means the TSH is very much high and the T34 are low. So what are the causes of primary causes are iron deficiency. All these we have discussed. Okay, so I'm just rushing through it. Iron deficiency or congenital hypothyroidism, like this agenesis, autoimmune conditions like Hashimoto's, hydrogenic, like when we give some radioactive iodine, total thyroidectomy, drugs like antithyroid drugs, infiltrative diseases like radials, amyloidosis, sarcoidosis, and sometimes there are also transient causes of hypoallergenic postpartum, subacute thyroiditis, withdrawal of the thyroid treatment. So all these will cause hypothyroid. Secondary causes like hypopituitarism, Sheehan syndrome, isolated TSH deficiency, or some hypothalamic disease. So without residual thyroid function, what we do is when there is no thyroid in the body, means you have removed the thyroid after thyroidectomy. So what you do is you do a replacement dose. You give T4, calculating it by like 1.6 microgram per kg body weight. That is generally we start with 100 or 125 mcg patient, and then we keep the patient in the follow up, and later on, if required, we decrease it. But generally, minimum 100 mcg is given lifelong to the patient. So when there is no residual thyroid function in the body, then you have to give a replacement dose. The adult patients who are under 60 without any heart disease, you can start from 50 to 100. Dose adjusted on basis of TSH levels. If the main goal of the thyroid management is you have to maintain the TSH under normal levels. So you have to follow the patient every 3 months or at least every for 6 weeks, and you need to repeat because the half life of the T3 and T4 is around 6 weeks, right? So you have to every 6 weeks or every 2 months you have to call the patient back. You have to measure the TSH. If the TSH is maintaining, then you need not alter the dosage of the thyroid which you are giving. But if it is increasing or decreasing, then you have to do an increment of 12.5 or 25 mcg, or you have to decrease it accordingly. And when the total thyroid has been removed, so the full replacement is achieved, for then the follow-up measurement of TSH is done every yearly, and it is extended to every 2 to 3 years. So when we have fully replaced the TSH with the thyroid drugs, then you have to measure TSH annually, and then keep the patient in follow-up. So what are the thyroid cancers? How do you manage the? So that was up till the non-malignant conditions. Now, how do you manage the thyroid malignancies? We have all these conditions: papillary, follicular, medullary, anaplastic, and coronary deficit. The most common is papillary. So how do you manage? You manage it by doing a surgery, by radioactive iodine giving, iodine 131, or external beam radiotherapy, thyroxine therapy, and also chemotherapy. So when you have a stage 1 and 2 papillary and follicular thyroid cancer, the treatment of choice is you do a total thyroidectomy. You also subject the patient to post-surgery with iodine 131 radiotherapy, and then if at all, if it's a stage 1 and only some part of the thyroid is involved, then you can also plan for a subtotal thyroidectomy. That is, you can leave a small tissue of the thyroid, that is the uninvolved part of the thyroid with the malignancy. The superior pole of it, only around around a chunk of thyroid tissue is left. So that is known as subtotal thyroidectomy. If the patient is has been staged as stage 3 papillary and follicular thyroid cancer, then you have to go for subtotal thyroidectomy. That is confirmed. Iodine 131 post surgery is given, radiotherapy, and external beam radiation therapy if iodine 131 uptake is minimal. Means after the surgery, you do a radioactive iodine scan, and accordingly you give the radioactive iodine ablation, that is I-131 treatment. If that uptake is minimal, I mean there is no improvement after giving the iodine uptake 131 also, then you can also go for an external beam radiotherapy. If it's a stage 4 papillary and follicular thyroid cancer, then the option is you don't generally go for a surgery. What you do is you directly destroy the thyroid tissue by giving iodine 131. Then sometimes external beam radiation therapy is also given. Resection of the limited metastasis, metastasis to the lung or to some bones or to some other neck, to various parts of the neck, right? So you have to resect that. THC suppression with thyroxine. So surgery is only done till stage 3 of the papillary and follicular. When it is stage 4, then you have to go for an radioactive ablation. Okay. So how do you treat the medullary thyroid cancer? You do a thyroidectomy, that is an thyroidectomy total, following it with central lymph node dissection, that is level 6 nodes. Lateral jugular sampling is also done. If you are suspecting any metastasis, then you have to do a FNAC of the lateral neck or a frozen section of the lateral neck nodes. And if they turn to be positive, then you have to do a modified radical neck dissection. External beam radiotherapy is given, and palliative chemotherapy is also suggested in the case of medullary thyroid cancer. And the family, as it has a family, the family members are also getting involved in this treatment, right? So it's better to give the patient the family members for raised calcitonin, screening for ret mutation, and prophylactic thyroidectomy. It's a familial disease, medullary thyroid cancer. So you have to screen the family members also, the first degree relatives and the second degree relatives. Coming to the anaplastic thyroid cancer, which is the most aggressive type, and this condition has the extensive extrathyroidal involvement. So the only you have the patient, the mortality is very high, and the chances of 1 year survival is less than 5%. So to improve that, you do a surgery immediately. As it's an extensive disease, you have to do a tracheostomy to retain means to pay to keep the patient with adequate respiration. So you do a tracheostomy, you do a total thyroidectomy, and radiation therapy is given, chemotherapy is given. So all the modalities of treatment are given to the patient with anaplastic thyroid cancer. Despite of giving this much treatment, the survival chances of patient is less than 10%. Now, briefly, I'll just tell the thyroid surgery. So surgery is the definitive management of thyroid cancer, excluding most cases of ATC, that is anaplastic thyroid cancer and lymphoma. So what are the type of surgeries? Lumpectomy. So what do you mean by lumpectomy? Lumpectomy is, so till now, have you followed someone? Please, can someone respond?
Yes, yes, sir.
Okay, so we have discussed the hyperthyroid, how to treat the hyperthyroid, how to means we have discussed the total non-malignant and malignant, what to do. So when what do we do a surgery? And just I'm telling now. So what do you mean by lumpectomy? So lumpectomy is you just remove that lump of the thyroid nodule. You don't remove the whole one part of the lobe or the more of that. Only that part of the swelling of the thyroid gland is removed. That is known as lumpectomy. Generally, this is not only done for benign conditions and not practiced nowadays. It is not at all practiced nowadays. We generally go for a thyroidectomy, hemithyroidectomy. We remove that part of the lobe. Partial thyroidectomy, also known as hemithyroidectomy, total lobectomy or hemithyroidectomy. So all these are the similar. Actually, the nomenclature, the new guidelines have totally changed. Now there is no terms known as lumpectomy or partial thyroidectomy. The only condition is known as hemithyroidectomy. Subtotal thyroidectomy is also, which I have already told you, means. So see, this is the thyroid gland, this is the trachea. So when you remove the half of the thyroid gland, which is known as hemithyroidectomy. Okay, this is the hemithyroidectomy. When you remove the more than half, means only you keep only this part of the thyroid gland, then it is known as subtotal. Okay, this is known as lumpectomy, this is known as isthmus. Okay, so this is the isthmus. So isthmectomy, you own only the isthmus or the pyramidal lobe is involved, then you can also, what you can do is you can just remove this isthmus. This is the isthmectomy. This is also a type of subtotal thyroidectomy. This is total thyroidectomy, you remove the whole total thyroid gland. This is the whole total thyroid gland, total thyroidectomy. So what do you mean by near total? Near total is almost like subtotal, but you remove more than that, and you remove means you keep only a small tissue with one of the parathyroids or two of the parathyroids, and you remove the whole of the thyroid gland. So in the new guidelines, only terms used are hemithyroidectomy, subtotal thyroidectomy, and total thyroidectomy. We don't have much of these other conditions. Only hemi, subtotal, and total. So these are the three conditions now generally done. So with only so how do we do a thyroid surgery? The incision taken is focus incision. So this is how you place the patient. You keep a folded sheet or a towel behind the neck so that the thyroid gland is pushed up. That you have to flex the neck. You have to flex the neck, and you have to keep a towel beneath the neck so that the thyroid gland pushes up, and it gets totally visible to the surgical field. So this is the incision where this is known as coccus incision. This is the sternocleidomastoid on both the sides. So you're from one side of the sternocleidomastoid to the other side, 2 finger breadth above the suprasternal notch. 2 finger breadth above the suprasternal notch from one side of the sternocleidomastoid to the other side, anterior borders. You give an horizontal incision, which is known as Cocker's incision. So this is the axial section. So you give an incision like this, and so this is the skin, this is the subcutaneous fat, and this is the platysma. So the platysma is the one which is the outermost, just beneath this subcutaneous layer. Then you have the strap muscles. So this is the sternothyroid muscle, and this is the sternothyroid muscle. So these are, you have the strap muscles. This is the thyroid gland, enlarged thyroid gland. So you incise here. We will go one by one. Okay. So in this picture, what you're seeing is, so this is the thyroid gland, this is the sternohyoid muscle, and this is the sternothyroid muscle. So these are the strap muscles which keep the thyroid inside them. It's protected. So our trachea is protected by the thyroid gland and the strap muscles. So so that there is no injury to the trachea. So in this diagram, you're seeing this is the sternocleidomastoid muscle, this is the sternohyoid muscle, this is the sternothyroid muscle. So on the opposite side, you have the sternohyoid muscle is cut here. Just this is the, when you cut the sternohyoid muscle, you are able to see the sternothyroid muscle. Understood? This is the lateral view showing. This is the means we ligate 3 parts of the thyroid to remove that gland. We ligate the middle thyroid vein. See, this is the middle thyroid vein. We have to ligate this first to rotate the thyroid gland medially. Then we ligate the superior vessels and the inferior vessels. So superior pole of the thyroid is divided here, and the inferior is divided here. That after doing this only, you can remove the thyroid gland. So you ligate 3 vessels: middle thyroid vein, superior pole, and the inferior pole. At the superior pole, you have superior thyroid artery and superior thyroid vein, and the inferior pole, you have inferior thyroid artery and inferior thyroid vein. So like this, you give an incision, then subplatysma. This is the platysma. So platysma is divided, and you have to raise the superior flap and the inferior flap. Okay. Then the first vein which is most likely to be encountered is anterior jugular vein. So when you give an incision, you give an incision on the skin. Then the subcutaneous tissue is subcutaneous fat is removed. Then the platysma is identified. The platysma is pulled above. Then you will find the anterior jugular veins. You need to cauterize these, otherwise you will have a lot of bleeding in this area, and the surgery will be difficult for you. So you need to identify these anterior jugular veins and ligate it. You can do a finger dissection. Means you can subplatysmally you can put so your finger, and you can do a dissection so that you won't injure much of the vessels. Okay. And then you are making the incision over the sternomastoid muscle, or else you can also retract this. No need to incise generally. You can also retract. You have some retractors, so you retract the sternocleidomastoid muscles on both the sides. So that will bring the strap muscles into your vision. If you don't retract the sternocleidomastoid muscle, then you won't be able to see the strap muscles. So this is this is the sternocleidomastoid muscle. So they have incised it, and they have now what they're doing is they are retracting it. So this is the axial section. This is the sternocleidomastoid muscle. See, this is the sternocleidomastoid muscle. When you retract this, then you have sternohyoid and the sternothyroid muscles. These are strap muscles. So if you don't retract this, you won't be able to see this. So the first muscle you need to retract is sternocleidomastoid, then the sternohyoid muscle, then the sternothyroid muscle. So when you retract all these muscles, then the thyroid gland will be visualized. So strap muscles are generally you divide in between. You divide the strap muscles in between and you retract it. Okay. This is the anterior view. So like this, in midline you have incised. Now you are sternohyoid muscle, you are retracting it. then the sternothyroid muscle. We have already retracted sternothyroid. Now the sternothyroid muscle has come into the picture. Then you will also remove that. Okay. So sternocleidomastoid, sternothyroid, all these muscles have been retracted, and you can use your fingers to dissect the muscles. Then you have to identify the middle thyroid vein, so that if you don't like it, the middle thyroid vein, then you cannot pull this thyroid gland like this medially. If you have to like identify this, the first step when you identify the thyroid is you have to identify the location of middle thyroid vein. So once you have ligated the middle thyroid vein, you can pull the means you can pull this part of the thyroid gland medially, and you can start dissecting the other superior pole and the inferior. So this is the superior pole. Okay, so this is the superior pole you are dissecting now. So superior pole, you have kept clamps and you have identified all the vessels, and you will ligate all the vessels and you will cut like this. Then middle thyroid vein is also secured, superior pole is secured, then you go for the inferior. So this is the inferior thyroid vein and artery. So you will ligate these vessels. So first middle thyroid vein is ligated, then superior pole, then the inferior pole. Okay. This is the lateral aspect. Okay. So the middle thyroid vein has been ligated here, the superior pole has been ligated, the inferior pole has been ligated, and the total thyroid gland is pulled medially, means you pulled it to the opposite side. Then you will identify the parathyroids. You will identify the recurrent laryngeal. So this is the recurrent laryngeal now. You have to preserve this. Okay. This is the recurrent laryngeal now. This is the trachea. Sorry, this is the trachea. This is the trachea. This is the recurrent laryngeal now. This is the inferior thyroid artery. So you need to identify all these, and then preserve the important structures and remove the thyroid gland. Okay. So all the clamps are kept and you are removing it. Thyroid gland has been removed. This is the thyroid gland which we are removing. Okay, this is the thyroid gland which is being removed. See the okay. So now this is the last one, last picture showing. This is the isthmus. Okay, this is the remnant thyroid remnant which is kept. The ligated lower pole. This is the ligated upper pole. This is the stump of the middle thyroid vein which we have ligated. So this is how the neck should be after doing the surgery. Then we suture the sternothyroid muscle first, then the sternohyoid muscle, and last the sternocleidomastoid. So whatever the muscles you have retracted, you have dissected, or you have resected in between as they were coming in your way, you have to suture all the muscles. The first muscle which you will be suturing is sternothyroid, followed by sternohyoid, and the last will be sternocleidomastoid. Okay. So these are this is how you will suture. Then then the platysma has to be sutured. At last, the skin will be sutured. So, what are the complications of doing this after doing surgery? The immediate complication will be hemorrhage. If you have not ligated any of the superior pole or the inferior pole or the middle thyroid vein not properly, then you will have immediate hemorrhage. Infection can be there if you remove some. If the sterile conditions are not maintained, then infection can be there. Recurrent laryngeal nerve palsy. If you don't identify the RLN nerve and you do surgery very aggressively, then you are the more chances of injuring the recurrent laryngeal nerve is there. Thyroid crisis can happen, or storm can happen immediately due to the release of the thyroid, excessive thyroid into the bloodstream. Thyroid crisis can happen. Respiratory obstruction can happen if by accidentally if you have injured the trachea, then some tracheal tracheitis can happen, or the laryngeal edema can happen. So respiratory obstruction will definitely be there if you have injured some of the important structures. Parathyroid insufficiency or tetany. Accidentally, if you have removed the total all the four parathyroids, if you are not able to preserve any of the parathyroids, then hypocalcemia will occur. So parathyroid insufficiency can occur in cases like thyroid surgery. What are the late complications? Thyroid insufficiency means you have removed the total thyroid, but you are not giving the supplement. You are not supplementing enough thyroid. Then the thyroid insufficiency can happen. Recurrent thyrotoxicosis can happen. Progressive exophthalmos or hypertrophic scar of keloid. So these are the late complications. Generally, external beam therapy is not given. Only iodine 131 radioactive iodine is given. But sometimes, if needed in extensive conditions, you need to go for external beam radiotherapy. So it can be used as primary treatment. It can also be used when there is local invasion or residual micro or macroscopic disease is there, or some if you have if the patient refused for radioactive iodine, then you can also go for external beam therapy, or if they are allergic, then also you can go for external beam radiotherapy. Solitary osseous metastasis, only at one place the metastasis is found after doing a PET scan, then you can also go for an external beam therapy. Chemotherapy drugs which are given are doxorubicin and cisplatin. So these are the two drugs. Chemotherapy is generally given only for stage 4 conditions, or generally given for medullary and anaplastic, but papillary and follicular are generally treated with surgery only, and this is how the surgery is done. Okay, so I'll share you this PPT. You can just go through these pictures once again so that you will understand how the thyroid is surgery is done. And so this was the topic. Now you will be again taught the same thyroid in the general surgery classes also. So I'm not going into much details. Luckily, you won't be getting any thyroid case in your ENT practicals. So you just read this for your theory exams. Okay. If anyone of you have some doubts, you can unmute yourself and ask me, or else we will conclude the class here. And you guys, please once again go through all the topics already taught to you. And if you have any problem, means if you want me to repeat some of my topics, any topics, because now we are into the revision phase now. We need to revise the classes, so it's better you just once go through the topics. If you find some difficulty, please let us know so that we can help you out. If everyone has marked your attendance and you don't have any doubts, then you can leave the class. I'll be closing the class in 2 minutes. Thank you.